Hello, everyone, and welcome to today's P2P workshop, The Role of Internationally Educated Health Professionals in Addressing Canada's Health Human Resource Crisis, Intersectoral Collaboration to End Underutilization Through Systems Change. Before we begin, I'd like to begin with an acknowledgement that N4 is hosted at CHEO. CHEO is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe territory have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples and their valuable past and present contributions to this land. My name is Mariah Maddock, and I am a Partnership and Engagement Lead with N4, which stands for National Newcomer Navigation Network. I will be chairing today's workshop and moderating the question and answer period today. And I'm joined here today with speakers from the National Newcomer Navigation Network and World Education Services. And I'll now introduce our speakers for today. Our first speaker is Dr. Sahar Zomi. Sahar has a master's and doctorate degree in pediatrics from Alexandria University in Egypt. She has 25 years of clinical experience as a clinician, lecturer, and researcher at Al Shatbi Pediatric University Hospital in Egypt. Sahar then worked as a pediatric nephrology specialist at Nottingham City Hospital in England. Upon completion of her Master of Health Administration, Sahar led roles in quality improvement and patient experience, including building the hospital's participation in the Solutions for Patient Safety program. Sahar built upon her experience in evaluating and documenting CHEO's efforts to promote equity for its Syrian refugees to co-design the development of N4. She now leads the N4 team in reaching their goals to create a national network aimed to improve the experience of newcomers in navigating Canada's complex health and social service systems. And our next speaker is Carl Flecker. Carl is currently serving as the Associate Director, excuse me one second, the Associate Director of Policy and Advocacy with WES Canada. Carl has worked in various roles addressing labor migration issues nationally and globally. Carl has also served as the National Director of Human Rights and Anti-Racism with the Canadian Labour Congress, and has done time with the immigration and settlement sector, academia, and governments. Carl also contributes to public policy research and action campaigns. And our next speaker today is Caroline Ewan. Caroline is a research and policy analyst with WES Canada and alumnus of the University of Toronto Munk School of Global Affairs and Public Policy. Prior to this, Caroline worked at the Canadian International School in Amman, Jordan, and at the Immigrant Education Society, TIES, in Calgary, Alberta. Caroline recently co-authored the policy brief addressing the underutilization of internationally educated health professionals in Canada, what the data does and doesn't tell us. Throughout today's presentation, we invite all of you who have joined us today to enter your comments and questions in the question and answer box today. We have left time at the end of the presentations to address your questions. The Q&A box can be found in your Zoom toolbar. And you also have the option today of upvoting questions, and we'll prioritize which questions we ask to the speakers based on your upvote. And we'll start off today with a presentation from WES that will provide context into the underutilization of internationally educated professionals and recent initiatives WES has undertaken to support internationally educated health professionals. WES has been a strong collaborator with N4 to look at ways we can evoke systems change to end the underutilization of internationally educated health professionals. And I'll pass it over to you now, Caroline.
Great. Mariah, I think I'm going to start off. It's Carl. Sorry, my video is off just because we've had hydro problems in Eastern Ontario and I didn't get a chance to press my pajamas. So you'll have to just do. Just to share with you, we've got 4 points in our agenda. We want to provide you with some background context. We want to talk a little bit about recent initiatives supporting internationally educated health professionals. We want to outline a bit of an integrated strategy, and finally, some information on WES's approach. The next slide. We really thought it was important to start this off presenting the voice of internationally educated health professionals or health workers. And so the Institute for Canadian Citizenship did an equal chance campaign, and we're going to share a short video that has their voice. This refers to doctors, but many of the issues they raise are still relevant to other health professionals. Over to you.
أهلا وسهلا بكم.
Namaste.
Assalamu alaikum.
My name is Dr. Mithi Lowry.
Je m'appelle Prinsila Mokoko.
Sugandha Agarwal.
My name is Harry Tabrizi.
I practiced medicine in Egypt for 10 years.
In Bogota, Colombia for more than 6 years.
Au Cameroun pendant 2 ans.
For 15 years.
For 20 years.
I became a doctor because I wanted to make a difference in people's life.
To care for others in their most vulnerable times.
To serve the community.
Je suis devenu médecin parce que je voulais pouvoir venir en aide aux gens.
I have completed and excelled in the Canadian qualifying exams.
I meet Canadian standards, but I'm prevented from being your pediatrician.
Your anesthesiologist.
Your psychiatrist.
Your obstetrician and gynecologist.
I am a doctor.
I am a doctor.
Je suis docteur.
I'm a doctor.
But not in Canada.
That's great. Thank you, Caroline, for sharing that video. So some really talented people and who've been struggling to re-enter their careers. I'm going to turn it to my colleague, Caroline, for the next bit of information.
Thanks so much, Carl. So I'm going to set some context before we dig in further, likely some context that folks here will be familiar with, which is the health human resource crisis and also the underutilization of internationally educated health professionals that we see in this context. A survey from 2022 showed that nearly a quarter of nurses intend to leave their job in the next 3 years. So some really significant burnout amongst the nursing workforce. We know that Canada already ranks very poorly, 27th out of 38 OECD countries in its physician to population ratio, and the number of physicians that are reporting high levels of burnout has nearly doubled over the pandemic. We also know that there's inequitable access to care in rural and remote regions. So all of this contributing to a really significant, crisis in the Canadian health workforce. And at the same time, what we're seeing is really significant underutilization of the skills and training of internationally educated health professionals, or IEHPs. We're seeing record high immigration targets, including some occupation-specific draws through express entry that prioritize individuals with health education. But we see this disconnect between immigration, registration, and employment, contributing to underemployment and underutilization. And this issue is really, it's a wicked problem. It's not new. This has been around for decades. And part of this has to do with the really complex ecosystem that this issue sits in. You can see on the right of the slide here, the many different stakeholders that are involved in this issue. It's interjurisdictional. There are many stakeholders with overlapping and sometimes competing interests, priorities, and responsibilities. So this complex ecosystem really worth noting in terms of why this issue is so intractable and why it's challenging to address it in a really systematic way. So moving on to what we know about the skills underutilization of IEHPs. In fact, we know a fair amount. We know that almost half of IEHPs are unemployed or underemployed. For physicians, this has to do with inequitable access to residency training, insufficient opportunities to maintain their recency of clinical practice. And for internationally educated nurses or IENs, we know that multiple barriers intersect and shape underutilization as compared to Canadian trained nurses. So we know that only 37% of IENs with a bachelor's degree obtained internationally were working in their field in 2021, as compared to a much higher proportion, nearly 80% of Canadian trained nurses. One interesting point to emphasize here is that some recent research showed that about a quarter of recent immigrants working as nurse aides, orderlies, or patient service associates hold at least a bachelor's degree, and of these, 69% hold a nursing degree, which is a really significant proportion. It's worth noting here, we know a fair amount about underutilization, but we also don't know a fair amount too, and this is related to gaps in the existing data that's being collected about individuals with international medical or nursing credentials, or all IHPs really. Data on fields of study, intended occupation for immigrants arriving to Canada are not being systematically collected for all immigration pathways. So for example, many temporary residents don't have their field of study or intended occupation captured when they arrive to Canada. And data from regulatory bodies at the provincial level is also disconnected from immigration data and employment data. Why does this matter? Well, we know that there's a really high degree of underutilization that's being shaped, but not accounted for in the labor market. And what results is a lose-lose situation, both for these highly skilled individuals, as well as for Canada's healthcare system. So turning now to, what's being done to address this crisis and this issue. So looking at some recent initiatives at both the provincial and federal levels across Canada. WES has been tracking these and also drawing on scans by partners to get a picture of what's happening across the country. So I'll just briefly speak to some examples under kind of the buckets that we see here to highlight the incredible amount of work that's being done in different areas. So starting on the left, financial supports. Currently, we see, in several provinces, bursaries, grants for tuition support, tuition reimbursement for IENs. Several provinces have also introduced temporary reimbursement of registration fees for IENs as they pursue the process of licensure. We also know that there are, microloan services for physicians. So Windmill microlending is one good example, microloans to support with the licensing and accreditation process for physicians. So financial supports we're seeing, for several different occupations. We also see navigation supports and access hubs across the country. So in Ontario, the Health Force Ontario Access Centre for IEHPs is a good example. There's an IEHP Access Hub in Manitoba through the University of Manitoba. And an interesting example of a navigation service is the IEN Navigation Service in New Brunswick, which to date has matched over 200 IENs with employers. We're also seeing an expansion of educational and training seats. So Ontario and other provinces are expanding the number of bridging seats for IENs, including hybrid course options. So folks can, complete, courses specific to the gaps and competencies that have been identified in their training. So a modular approach to bridging. We're also seeing an expansion of practice-ready assessment positions for physicians, which I'll speak to more under supervised practice and assessment opportunities. An interesting development in recent years is also what we would call fair access legislation. So in Saskatchewan, for example, we recently saw the Labour Mobility and Fair Registration Act. And so what this does is to establish a fair registration practices office within the Provincial Ministry of Immigration and Training. In Ontario, there's an interesting bill, Bill 106, which was the Pandemic Emergency Preparedness Act, which removes Canadian experience requirements as a qualification for registration, but in non-health occupations. So an interesting example of, an approach that could be applied to health occupations in the future. Newfoundland and Alberta have also introduced Fair Registration Practices Acts. So looking to kind of codify what other provinces have done through fairness commissioners and ensuring that internationally trained individuals can access the licensing and training opportunities that they deserve. Moving on to supervised practice and assessment opportunities. Some interesting examples recently in Ontario, recently launched the Supervised Practice Experience Partnership, or SPEP. So this is collaboration between Ontario Health and the College of Nurses of Ontario, where internationally educated nurses can work under supervision in hospitals, in long-term care, while completing outstanding registration requirements. So for example, demonstrating language proficiency or getting their recent hours of practice. There's also an interesting model of defined registration for physicians in Nova Scotia that was recently introduced, where ITPs, or internationally trained physicians, can work under supervision on a defined license. They get a comprehensive orientation, a short period of supervised practice, and then they are fast-tracked in terms of their eligibility for independent licensure. So some very interesting new approaches to supervised practice. And then very briefly on the right, worth noting that across the country, we're seeing regulatory modernization. So this includes, temporary licensing, modernization of language proficiency requirements like we saw in Ontario. Another interesting example is the regulation of clinical associate roles in several provinces, where internationally trained physicians can work on a defined license as clinical associates, as opposed to pursuing full licensure. On the far right there, there's also been significant federal action in recent years on this issue. So recently, the Canadian Medical Association, Canadian Nurses Association, and the College of Family Physicians of Canada made policy recommendations to the House of Commons Standing Committee on Health, or HESA, and HESA recently released their report addressing the health workforce crisis, which has several recommendations that acknowledge the role of internationally trained health professionals in addressing the workforce crisis. And Carl will speak a bit more to some work by Health Canada that is ongoing. So, what does this all say? A lot is going on, a lot of money is being invested, and WES and others are calling at this point for a coordinated strategy. This issue is pan-Canadian. Something can work really well in one jurisdiction, but that doesn't solve the issue at the pan-Canadian level. And so the federal government certainly can play a role in coordinating efforts in partnership with provinces and territories to really drive this pan-Canadian health human resource strategy. And this is something that Carl will speak to in a moment. I'll pass it back to you, Carl.
Thanks, Caroline. So the next slide, Caroline has set me up well. We're really calling for an integrated strategy, and there's three big circles, and there's a host of systemic barriers within each of these, whether it's immigration, the registration or licensure process, and then the actual employment in different healthcare settings. And I'm not going to go into the detail about the problems within each of those areas, but I will just highlight some of the remedies that we're calling for in each of those three circles. And the first one related to immigration is removing barriers that are related to a person's immigration status. And that means enabling IEHPs who've arrived in Canada as permanent residents to be able to transition they either arrived as permanent residents or they're in the process of getting PR. But the kinds of remedies we're looking for here is allocating more spaces in the provincial nominee programs, targeting health professions in federal economic integration programs. And here we also have to be careful to adhere to the World Health Organization's principles on ethical international recruitment. Some people may have seen recently in the media, the United Kingdom recently banned recruitment of nurses from Nigeria. But unfortunately, in Canada, we still have some provinces tripping to places like the Philippines for recruitment efforts. Also under the IEHP category in immigration is for those who have not yet achieved permanent resident status. Those folks need open work permits. They need to be able to have access to provincially funded bridging programs. There needs to be conditional registration while a person is waiting for an open work permit or permanent residency to be approved. In the circle around facilitating registration, we need to ensure that programs that bridge gaps to registration for IEHPs are widely available and that they're integrated within the healthcare education faculties. They need to be funded in an ongoing operating grants basis. They need to be scaled up and adapted for other professions in healthcare based on workforce demand, supply, and evaluation data. And there needs to be supports for clinical supervisors and participants. In the third circle, around enhancing employment opportunities, there's much that can be done about better linking employers and community organizations who can assist employers to gain access to IEHPs. That there can be good sharing of best practices and equitable and inclusive recruitment and workplace practices. And there also is a reality that in healthcare, there is a race and gender dynamic going on in this particular workforce that needs to be addressed. So all of those three circles culminate and lead to the need for an HHR or health human resource strategy that is inclusive of internationally educated health professionals, that includes them as intentional and integral part of the healthcare system, that is informed by the principles of equity, diversity, and inclusion, that is informed by the collection of disaggregated data on both the provider and the patient side, and it includes the consideration of the three elements: immigration, registration, and employment. And this should be something that is led by government and developed by bringing all the relevant stakeholders to the table. And here, when West began this work at the onset of the pandemic in 2020, 2021, at that moment in time, it seemed obvious that tapping into the thousands of available internationally educated health workers was at least a short-term remedy to the crisis that was unfolding. But looking back, it's kind of revealing that even a global pandemic, a catastrophic health human resource crisis, really has not been enough to kickstart a truly radical retooling of our systems that have long impeded efficient career reentry for health professionals. Now, that's not to say that there hasn't been significant changes in policies, increased funding, and attention of the plight of health workers. Caroline has done a great job of summarizing that. And yet, many of us would also argue that despite these gains, we have still yet to see a systems approach come into play. Now, we opted to pursue an occupation-specific engagement strategy, and that was due to several reasons. Some data was available on the number of internationally trained docs and nurses, and as Caroline has pointed out, we have to put the caveat that data is notoriously problematic. Two, these occupations were facing serious challenges: burnout, workplace exodus, etc. Three, other occupations of the sector, they quite frankly were not as prominent to policymakers and the public, though many of the same system level barriers exist for those folks, be they dentists or respiratory technologists and so on. So our strategy was to begin with these occupations, docs and nurses, and then apply what might be transferable to the other occupations. And lastly, we opted for this due to organizational capacity. Now, initially, allies noted that beginning with a provincial focus, specifically Ontario, that had some internal logic. The majority of the newcomers land here. This is home to key regulatory colleges. And then there's the Fed-Prov jurisdictional realities within the healthcare file. Also, experience dictated that systems-level remedies required more than just the regulators or the health colleges to be at the table. As Caroline pointed out earlier, the healthcare ecosystem is populated with many diverse stakeholders, and each of these players has a defined role, their budgets, infrastructure, policies, and their own systems. It's complex, and so systems level changes dictate that all of the stakeholders need to be invited into the same room. Now, some of them may have to be sequestered, some may need a carrot, and or a stick. And of course, some are genuinely interested in finding remedies. My point is, it's a complex system that requires bold participation of all of the players, including the internationally educated health professionals. So we've been advocating for that system level change using a multi-stakeholder process in order to develop a comprehensive health human resource strategy. Now, governments really should be the ringleader or the lead agent for this type of strategy to have traction. But then again, governments can be self-interested. And I really welcome in the Q&A section to hear your comments on this point. Are governments, in fact, the best stakeholder to be honest brokers to advance a multi-stakeholder process? Could it be an informed public? What about a coalition of champions? Just something to think about. Finally, while we began this work focusing on 2 occupations and centering our efforts in Ontario, as Caroline pointed out, this is a pan-Canadian problem. The recent First Minister's Health Conference, the healthcare transfer deal, the interjurisdictional nature of health policy, the role of immigration, the national labor market development, alongside the provincial and territorial counterparts, means that there must also be a federal level health human resource strategy. Now, we see this with recent policy recommendations made by the House of Commons Standing Committee on Health, Health Canada's efforts in October and November to develop what we know as the Internationally Educated Health Professionals Blueprint, which actually used a multi-stakeholder process and actually was developing some very specific remedies with a number of the key players around the table. We're still waiting for that to come out into public. And then there's the federal budget, which has seen increases in healthcare investments. These are just a few markers that really speak to the need for a national level agenda. So is it going to be easy? Not likely. Well, what else have you got to do? So I'll just close with, here are 3 publications that Wes has produced that you might find of interest. 1 is exploring the data challenges and proposed remedies. 2, we did this in concert with the smart folks at CERC. And here we unpacked key challenges to the immigration, licensure, and workplace integration buckets, and we put forward some policy remedies. And finally, Caroline was the lead author of a very thought-provoking paper that looks at the benefits of bundling remedies, such as establishing a clinical associate class of license for doctors, bringing equity to the distribution of residency seats, and scaling up program called Practice Ready Assessment for internationally trained docs as part of system change, all of that as part of a systems change package. I'll close there and hand it back to Mariah, who's got some stuff to add.
Wonderful. Thank you so much, Carl and Caroline. That was such an informative presentation with so much valuable information. And we're now going to jump into speaking a little bit about how N4 has brought together partners, taken a multi-stakeholder approach to this issue through our community of practice. So I'm going to hand it off to my colleague, Sahar Zoni.
Thanks, Mariah. Thanks, Caroline, for setting the ground on a huge issue that our healthcare system has gone through. And I think the COVID-19 crisis or COVID-19 pandemic has really highlighted all those gaps in our healthcare system that we are still struggling with. One of them is, of course, the health human resources and the shortages in staff, and also the burnout that the staff are feeling because of the pressures that they had been facing. Our system is in need of lots of changes, as Carl said, and we have embarked on this new project, new mandate in April of last year. Our initial initiative was really at N4, started in 2019, when we were given a funding to build a network and a national network across Canada to really be a platform for newcomers serving professionals from the healthcare and the settlement sector to connect with each other, learn from each other, and collaborate around newcomer navigation. And as Mariah mentioned in the beginning, we are hosted as N4 at a hospital, a children's hospital. And in 2016 and 2017, the hospital had a lot of Syrian refugees families come in, and Ottawa as a whole, as a city, had to struggle with, accommodating those families. They came to the hospital with lots of complexity. They had lots of needs, and as a hospital in the capital of Canada, the expectation was that for years and years now, these hospitals, our pediatric hospitals, have been among the healthcare system, receiving a lot of immigrants and refugees. So you would think that the settling and the work between the hospital, the collaboration between the hospital and the community and the settlement organizations would be strong ones. But on the contrary, these collaborations were very weak. Everyone was working in silos. So at that time, our patient engagement and patient experience department was seeking input from other pediatric hospitals like Sick Kids in Hamilton, and just to see, what are you doing about the Syrian refugee, the surge in Syrian refugees? And to our surprise, there wasn't much being done, and there was kind of a gap when it came to collaboration between the different sectors who would be really, they should be working together to kind of settle those immigrants and refugees. This is where we kind of got this idea of the need. There's a huge need for this pan-Canadian network. And our vision is that for all Canadians, Canadian newcomers, to have a consistent and an equitable experience in navigating our health and our social services during their settlement, which are already very complex systems for ones who are already born in Canada. So we started reaching out to different stakeholders from the healthcare and the settlement sector and social services early in 2019, to aiming to build this network. And our network has expanded over the years, and we currently have more than 250 organizations who joined our network. And we were able also to launch a website, newcomernavigation.ca. On that website, we were able to provide lots of tools and functionalities for our members. And so these tools, again, our aim was really to connect our members, to provide them with opportunities to learn from each other, and to also collaborate with each other. So in 2022, in April 2022 last year, we got this new mandate to look at another group that really struggle when they come to Canada, the internationally educated healthcare professionals, as they come as skilled workers and they are seeking employment in Canada, but because of lots of blockage in their pathways, they are unable to find opportunities of employment. And this is why we kind of built on their, really understanding what are their needs. And we started by looking for opportunities for them to discuss and maybe come forward with lots of their issues. So we host a meeting place on our website, which acts like a discussion forum for them. And we also host a lot of events. And these events are really for our members to come together, to reconnect and learn from what findings we have come across during all these site visits that we have completed. We host webinars, 2 webinars a month. And we also provide opportunities for professional development for our members. We do curate a lot of e-learning on our website. We add a lot of resources. We have currently more than 600 resources, and many of these resources, once we got our new mandate to look at what are the needs of the internationally educated healthcare professionals, are actually resources for them. We do share a lot of public data, And we have learned from our site visits and our interactions with a number of internationally educated healthcare professionals that many of the barriers for their integration into the system might be their awareness or their understanding of the Canadian culture, our current healthcare system, and how it differs among the different provinces. So we have a program that's a 3 months program that we co-developed with a university here in Ottawa, St. Paul University, and it's delivered to our internationally educated healthcare professionals. To date, we have been able to enroll more than 180 of them, and a third of those were able to take that program in French. We're going to be hosting this program and providing it again free of charge because it's covered by our funder IRCC in the fall of this year. So again, building on the our site visits and building on the findings and what Wes have shared, we were able to host a community of practice that I'll tell you more about in a minute. So we had already for meeting a lot of needs of our members from the N4 network, we hosted like a community of practice, which is a pan-Canadian intersectorial committee that really works on projects, and it's very time limited, it's action driven. And before our new mandate to look at the IHPSs and their integration into the labor market, we worked on having a Ukrainian toolkit for our members. We also worked on a position paper to promote interpretation for newcomers as they land into Canada, and also an Afghan toolkit for our professionals to use when the Afghan refugees started coming into Canada. So building on our experience with the community of practice, we put together a community of practice to look at the challenges and the barriers in the integration of the internationally educated healthcare professionals into our healthcare system. Our community of practice started by engaging first with the stakeholders from different stakeholders who are involved in the process of the foreign credential and licensing of the internationally educated healthcare professionals. So we spent maybe the first 6 months after we got our new mandate in April, looking at engaging with these stakeholders to really map the pathway to license for the internationally educated healthcare professionals. And thanks to Wes, of course, for being our strong partner at that time. We linked with more than 75 stakeholders, and we kind of were able to understand the different pathways, how they differ from different provinces, what are the maybe opportunities, and what are the gaps, and what could be, how could we maybe come up with actionable recommendations. So we created 2 community of practice working groups, one to look at internationally trained physicians and another working group to look at the internationally educated nurses, knowing how the shortages in the healthcare system was mainly of the physicians and nurses. We heard a lot during our site visits that the lived experience voice might be ignored or might be not at the table, and that's why we had, parallel to our internationally trained ITP working group and international IEN group, we also were able to host 2 consulting groups, one ITP consulting group from lived experience and another one for the IENs. We understanding how the employers were struggling also to employ the internationally educated healthcare professionals was very tempting to us. So that's why we started also an employer consulting project where we consulted more than 20 employers from different disciplines. So we connected with hospitals, community health centers, long-term care, to get a good understanding of, how the employers struggle with the recruitment of internationally educated healthcare professionals, and how when they recruit them, what would be the obstacles for them to retain them also. Our first report came out in February of this year, and in this report we share our knowledge and all the information we've learned from more than 75 stakeholder engagement over more than 6 months, learning about what are the barriers and challenges and what are best practices and research work that have been incorporated when we look at the internationally educated healthcare professionals and their integration into our healthcare system. So this report is available on our website, and we also hosted a webinar whereby we were able to share all the information in our report and get feedback from different stakeholder and attendees, which really enriched our findings and our report. We also have launched last month another report on our experience working closely with the employers. And we have also put together a toolkit for the employers to sharing some of the best practices for them and tools for them to recruit and retain internationally educated healthcare professionals. This toolkit is available on our website, and we are hoping to be able to have a checklist that will be created for the employers to assist them in recruiting and retaining IHPS. We're hoping to launch this shortly. We're also hoping that employers themselves will be able to share with us. So there is a subscription whereby they can share with us best practices, and we will be able to add and update those best practices to our toolkit. So as I mentioned, for our community of practice, one of our main goal was really to come up with a set of recommendations for internationally educated healthcare professionals, mainly internationally trained physicians and internationally educated nurses, and to have actionable and recommendations that we can work with different stakeholders on really making sure that these are discussed with our stakeholders, and they would be kind of, addressing all these barriers and challenges for the integration of ITPs and IENs. They will be available. Our 2 reports will be available for the ITPs on April the 19th of this month, and also for our IENs on April the 26th. We will host a webinar together with to launch these set of recommendations. And our co-chair for the ITP was John Altz from West. So John has been a lead for this work together with Carolyn and Carl. So and for our IEN, we're also hoping to host a webinar for on April the 26th to really go through our recommendations. And another thing that we heard, and it really came a lot, was really the complexity of understanding the pathways to license for internationally trained physicians and internationally educated nurses. So we've created visuals for those pathways, and we're hoping to be able to launch them by the end of this month. Another way of sharing, clarity on these pathways, and maybe simplifying the pathway for our internationally educated nurses and internationally trained physicians. So we're hoping to be able to share our recommendations. So we have a communication plan now. We're developing this communication plan, And our next step is really looking at our knowledge mobilization strategy. So in order to be able to action those recommendations and work closely with stakeholders. So we're going to be hosting one-to-one stakeholder meetings. And over the next 12 months, we're also going to loop back to our community of practice working groups and our lived experience group quarterly, on a quarterly basis, to engage with them and to follow up on our meetings with the stakeholder meetings, and address any actions that come out of those meetings. And we're currently also working on developing all our materials to support our knowledge mobilization plan. Thank you.
Wonderful. Well, thank you so much, Sahar, for that great overview of some of the work N4 is doing in collaboration with stakeholders to improve the pathways to optimal employment for internationally educated health professionals. That was great. At this point in time, I will just invite all the speakers to turn on your cameras if you're able to, and we'll enter the audience-led question and answer period. I see there's a lot of thoughtful questions in the question and answer boxes, so I encourage you to keep your questions coming. And I'm going to start with the one that I'm seeing first on my screen. And this attendee is noting that they are a researcher in immigration and an immigrant themselves. And they've observed a lack of information provided to immigrants upon arrival to Canada. And this lack of information can be even more pronounced in smaller cities such as Saskatoon compared to larger urban centers like Toronto. And so their question is, how does WES ensure that internationally educated health professionals are informed of the opportunities available to them to work in the health sector in Canada? So I'll direct that to you, Caroline or Carl.
Happy to start, and Carl, you could pick up as well. Thanks for this question. It definitely resonates with what we've been hearing, and I would say not only a lack of information, but sometimes conflicting information or too much information that kind of contradicts itself or is potentially unreliable. So it's definitely an issue that we see across the board, not only in health occupations, but others as well. So some ways that WES engages with this issue. One simple way, I guess not simple, but one specific way has to do with client referrals. So clients that come through WES for a credential assessment, we have a referral mechanism where individuals are referred to, organizations that are in that specific occupation and are referred to supports from there. In terms of the policy work that we're more closely engaged in, WES engages with partners who have it a little bit more closely in their mandate to do this type of work. But the issue obviously is that often it's in no one's mandate to do this. It's a bunch of different stakeholders that each hold a piece of the pie in terms of, if it's immigration information, if it's to do with licensing or registration, if it's to do with employment. To give the example of nursing, you've got, access hubs, navigation services, you've got the accreditation bodies, you've got community partners. There's a role for the Federal Ministry of Immigration, and whose role is it to bring all this information together? And so that's really what WES and our policy team are calling for, is this multi-stakeholder approach, so that all of the stakeholders who hold a piece of this in their mandate are working on these issues collaboratively, because it's interjurisdictional as well. It's not the federal government's job, it's everybody's job to bring together these this information in one way. Carl, anything you would add?
No, great job. I would just say, some folks are looking at simplistic solutions, such as dividing the cohort of health professionals to those who are not here yet. So to provide pre-arrival services or pre-arrival information. And that's generally a good idea, but then you have to think about who is going to be providing that. Is it objective? Is it credible? Is it up to date? And in the environment that we've just been describing, where things are changing week by week with a new program, which might have a contra impact on one province or another, it can become complicated. Then there's the information that's needed for the folks who are already here. And we are literally talking about thousands coming every year and tens of thousands who are already here in the country. So not an easy issue. And lastly, I think you pointed out that the challenge when it's a big urban center versus a small rural community, there can be interesting and innovative programs in small communities because they have more latitude. And similarly, there can be interesting ideas in big centers. But it isn't like there's one fact sheet that can solve this problem.
Great. Thank you so much, Caroline and Carl, for sharing your responses there. And Sahar, do you have anything to add to this issue of information sharing, accurate, reliable, credible information with IEHPs?
I think it's crucial, as Carl was saying, like pre-arrival information is crucial, right? And it can really help IHPs make the right decision, right? So we heard a lot about, if I had known, about this and this and that, maybe I would have started the process earlier, or I would have, taken some of the exams online. I mean, like, I think it's very crucial, and it's important to be transparent about this information that's available for our IHPs to help them really make informed decisions. So pre-arrival information is crucial. So if that can be made available and updated, again, that would be a big part, I think.
Great, thank you so much.
And sorry, I'm just gonna add that on N4, like, we are trying to also be as updated as possible. So we understand and we know that finding information even about the license process, right, and the foreign credential can be challenging if you're looking at multiple websites. So that's why we have an RSS feed that we launched last year for IHPS, whereby we share information on the N4 website. And they can also subscribe via email and receive this this news feed to their emails. So again, I encourage you to subscribe for our RSS feed at N4. And another path that we've been also trying to help with is really sharing information via our newsletter. So we do have a monthly newsletter that's specific for IHPS that we send on a monthly basis, other than our regular newsletter for our N4 members. Again, very open to what information needs to be shared. So if you have any feedback, if you subscribe and you have any special, or we're lacking in any way, or you feel that this information can be more helpful for you, just reach out to the N4 team, and we will be able to definitely add this source of information and have it updated and have it regularly on the website or via our newsletter.
Great. Thank you so much, Sahar. And this next question is open to all the panelists. Is it possible that many IHPs are highly skilled, but their training may have been conducted in languages other than English? How could this language gap be addressed?
I can take a start at this question. So language proficiency is another issue that we hear come up in terms of being a barrier for folks who are trained in a language other than English, being required to demonstrate proficiency in English or French in order to meet, for example, registration requirements with the regulatory body. So certainly this is a requirement of many regulatory colleges that applicants must demonstrate proficiency in English or French, related to ensuring patient safety, ensuring, communicative competence for folks who are becoming registered. There are, so there's, a number of standardized proficiency tests that folks would take as part of immigration or as part of, the licensing process. It's interesting to see some interesting examples of, we spoke to this a little bit under the regulatory modernization category of supports, where if somebody has, language proficiency as an outstanding requirement for registration? Are there ways that this individual can work on a defined license in a supervised capacity to work towards meeting that requirement and demonstrate proficiency while also working in that role? So no easy answer, but it's interesting to see some of the more innovative solutions around supervised practice that are being introduced for folks to be able to demonstrate language proficiency.
And if I could add on that, I mean, this is an area where you can easily slip into a somewhat xenophobic interpretation of what is preventing folks. Many of the health professionals that I interact with were taught in English. Their texts are in English. Colonialism has something to do with that, thank you. But the issue of how is a person's language proficiency assessed becomes the question. Which standardized test to use? What is the benchmark? How does that relate to competency? Those are more nuanced questions that need to be looked at. And I think that this is a sensitive area in terms of you do want to be able to communicate, and as our country increasingly diversifies with more and more languages, why wouldn't we want to have more multilingual healthcare workers with an increasingly diverse population? So just to be a little cautious on this particular point.
Well, thank you so much, Carl, for that added perspective, and Caroline for your response there. Sahar, do you have anything to add to this?
I just want to say that maybe our language proficiency tests need to be more, targeting the profession, right? So more occupational, right? So instead of using the regular IELTS and the TOEFL and so on, maybe using more language, occupational language assessment tests would really be able to identify, there's a need for more support for the IHPS to pass these exams, but I feel that the language tests themselves, language assessment tests, need to be more defined towards the IHPS and ones working in healthcare. And as Carl was saying, I think we are a very diverse community. So having international healthcare professionals join us from with different languages, I think this is something that we need to think about, because at the end they would be serving communities who are diverse just like themselves, right? So it might be looked as an advantage rather than as a disadvantage.
Great, thank you so much, Sahar. And there is an additional question here directed to you, Sahar, and I think you spoke a little bit about it earlier, but how does N4 inform internationally educated health professionals of the available resources?
So on our website, all the resources that we have are public. So we do have a public phase of N4, and we have a member-only phase of N4. So we were very keen to have all the resources, through the RSS feed, as I mentioned, available publicly for our IHPS. If an IHPS wants to have more specific resources, they can become members and they can join N4 as a member, and then they would have access to our library of resources. So more than 600 resources, as I mentioned, and more than 18% of those are in French. So we also host, like our webinars that I mentioned, the 2 webinars per month that we host, we record all these webinars, and they are, the recordings can be found on our website. And lots of these webinars, since we got our new mandate, have been targeting those issues with the, with the IHPS, and again, providing professional development opportunities. And the last thing I would mention is the SPU program. So again, registration is going to be opened, and through the SPU program, the team, the professors at SPU, they share a lot of resources, and through the different 6 modules that are provided to the internationally educated healthcare professionals, and they have access to these resources up to 3 months after the program. So again, lots of resources there and lots of support. And our newsletter again is another source that I would just refer to. Thank you.
Okay, thanks so much, Sahar. And this next question is open to all the panelists. The attendees, thanking everyone for your time and the informative talk, and curious whether any of the resources mentioned, developed by N4 or WES, address employers' biases in hiring immigrants. And they go on to say, despite being informed of the benefits of hiring internationally educated health professionals, is it possible that employers may still have implicit biases against hiring individuals from outside of Canada?
Yep. Is the short answer to that. There's been some interesting studies by what's his name, Oreopoulos, and a couple of academics who've done tests with studies with resumes that are identical but have a international sounding name, and there's a very high negative response rate correlated with that. And those tests have been done, those studies have been done a couple of times with the same kind of responses. But I think the most telling thing of those studies was when they actually interviewed the HR people and asked, so what's up? How come Mohammed didn't get the interview and Matthew did? And there was where it isn't just implicit bias, but it's covert or overt biases where people are making judgments about international folks. And so I think that component is very much there. I think we also see it in terms of where do racialized newcomers and women end up in the workforce, particularly in healthcare. There's a definite skew towards racialized women, racialized immigrant women in positions where they are overqualified and underpaid and on the front line. I really encourage folks, if you haven't picked up Nora Loretto's book, Spin Doctors, which has a great chapter on the systemic racism within the context of COVID. And she poses it in a very direct way. Is it ignorance or malice? And that is a rhetorical header. But I think there is ample evidence to say that there is overt as well as covert biases that are taking place in the workforce. The nature of the crisis right now is forcing some employers to get over it and say we need to address this, but it's still there.
Thank you, Carl, and thank you so much for speaking to some resources that can be accessed as well. And I see as well, Caroline has put a comment to this question as well with some of the ways WES works with employers to better understand and address the issue. Do you have anything to add to that, Caroline?
Nothing really further than what Carl had noted, but just to, in case folks are interested, some of our amazing colleagues at WES are engaging with employers more deeply on this issue. And so I've put a resource in the Q&A box if folks would like to learn more on our website.
Great, thank you, Caroline. And sorry, I know N4 has worked closely with health employers.
Mm-hmm.
Do you have any comments to add?
So other than the our current our current report on the employer, our engagement with employers, and our toolkit, which has multiple resources on our website, I would say we are also going to work with St. Paul University on a new project. So we're going to do some research around how fostering a culture of inclusive and EDI purchases would really kind of, in Ontario is, and how that's going to be working for different employers. So we just started this research work, and we're hoping to be able to kind of bring forward some of our findings from that research. And we're hoping also to be able to provide some training for employers. As Carlos mentioned, HR is kind of, we've met with a lot and they are either unaware of the how to recruit internationally educated healthcare professionals, or they are unaware of the tools that could help them as an organization even overcome some of those biases. So we're hoping to be able to follow up with the employers that we've met with and really work with them on making our toolkit kind of practically used by them, by their departments, HR departments.
Thanks so much for sharing, Sahar. I know N4 as well just last Wednesday hosted a webinar on equity in hiring and retention. And that can be accessed on the N4 website with resources. This next question is an attendee saying, thank you for the wonderful talk. It's great to hear what WES has been doing to support internationally educated health professionals. And they understand the focus is on supporting internationally educated health professionals, but are curious if WES plans to undertake any initiatives to support internationally educated immigrants in other occupational fields.
Sure, I'll start on that one. We do have a growing program on looking at the challenges facing international students. And we also, as Caroline mentioned, in terms of our department that works with employers, there's a whole range of occupational groups that folks are being assisted in that area. I think read that part of that question is also the question of Canadian experience. And so we've had some success through the work with healthcare, but to get provincial legislation to redress the Canadian experience requirement for designated professions and trades. So that is being removed. And I think of other examples where regulatory bodies like engineers have revisited their Canadian environmental experience requirement and saying they need to revisit that and change it. And so there are initiatives that are happening not only with WES's support and engagement, but also with some of the players who are in the field and recognizing that they're losing out on talent if they don't revisit their own barriers. And I think the engineers is one example of that.
Great, thank you so much, Carl. And Caroline, Sahar, do you have any additional comments?
Yeah, I would just briefly add to what Carl mentioned, kind of the WES, WES does credential assessments. That's the primary kind of core business, but also deeply engaged in kind of the social impact department through policy advocacy, program development, including those direct referrals, philanthropy and partnerships. So kind of bringing, lots of levers to bear. Not the presentation today is obviously specific to health, but as Carl mentioned, engaged in advocacy and policy advocacy in a number of other areas. So I'll add a link to that in the Q&A box as well.
Great, thanks, Caroline and Sahar.
At N4, we've always been keen on bringing the voice of lived experience. So we initially, when we engaged, even to map out the pathway and the challenges, we engaged with a number of internationally educated healthcare professionals, internationally trained physicians and internationally educated nurses, specifically to get their input and their, to get their understanding, and really we're keen to involve them and invite them to be part of our lived experience consulting groups on our community of practice. And we have shared with them our progress on the on the consulting groups, and also really carefully included all their input when it came to our drafting and our final recommendations. And we have also been very keen, on the SPU program to really get their input whenever there was, any feedback that they had for us around how the program is being delivered to them, what are their needs, should we change any of the modules that is being delivered. So I think we're incorporating their voice all the way through, and we're hoping to continue that through our coming work, on the knowledge mobilization and really reaching out to the stakeholders. So really advocating for these recommendations on and incorporating their voices in that, and getting their feedback, in every step through our quarterly meetings that we will have.
Great. Thanks, Sahar, for speaking about how N4 is engaged, the voice of lived experience. I think that was there's a question there, so thank you for touching on that. We have time for one more question today, and I'll start with the one that has the most upvotes. Are you aware of the experiences of internationally educated health professionals during the COVID-19 pandemic? as well as their experiences when they are overqualified for their employment positions. And this attendee is saying, additionally, they've read that immigrant women healthcare aides experience intersectional exclusion in Canadian long-term care. Do you have any comments on this particular issue?
Sure. Go ahead, Caroline.
Yeah, I'll start off here. This is definitely something that we've been looking into. As Carl noted, it's very interesting that, you know, in the context of a global pandemic, we still saw that IEHPs were sitting on the sidelines. In 2020, at the height of the pandemic, there were about 14,000 IENs waiting to obtain licensure in Ontario with the CNO, with some outstanding requirement. Short duration licensing for physicians during this time was also, you know, uptake was not where it could have been. And so very telling that even at the height of the pandemic, this underutilization was persistent. Wes held a series of focus groups with IENs back in 2021. I'll put the link to that, to the findings from that in the chat. There's also some great research segueing to the second part of the question by Naomi Lightman, who's a researcher out of U of C, you know, around the intersection of race, gender, and immigration status. You know, we know barriers related to immigration status. You can be ineligible for bridging programs, for licensure, barriers related to xenophobia, racism, and discrimination for immigrant women. And, you know, the unique challenges for women more likely to be primary caregivers in the household, more likely to, you know, need childcare. And so, you know, intersectional lens that incorporates all of these issues is critical to understanding this issue, especially in the design of, you know, interventions and supports. Are these voices being included in the design so that, you know, these perspectives are being considered as we try to address this issue? So I'll put two of the resources I mentioned in the chat for folks.
If I could, I would just add to what Caroline has laid out. We have to take a look at the systems that are perpetuating this. So when we have in long-term care, for example, workplace settings where people can't earn a decent wage, so they have to hold 2 or 3 positions at different facilities where there's a high risk of exposure to the pandemic, and they happen to be racialized women, that's a systems problem. I'm looking at Nora's book, June of 2020, 91,000 cases in Canada, 7,000 deaths, disproportionately falling on racialized communities and women. We look forward into this situation and we say, okay, how are we going to address this? The healthcare system is collapsing. Part of the remedy is internationally trained healthcare workers who are going to be racialized immigrant women. Are we making sound choices by putting talented, competent people in a time of crisis into a burning building? And that really is a powerful question we need to address. And back to Laura's heading, ignorance or malice.
Well, thank you, Caroline and Carl, for your fulsome response there. We are coming to the end of our time together today, and there's been some really excellent and thoughtful questions here. So the emails of the speakers are in the PowerPoint presentations, which have been attached as resources for this session. Please do reach out if you have any lingering questions or comments about anything that was shared. I also see that if you're looking to access the resources, the links that Caroline's been posting, you can find those in the answer tab of the Q&A window box. That's where all the answer questions have been moving to with those important links there. And we just want to thank you all. First of all, thank you, Sahar, Caroline, and Carl, for your time today, for taking the time to present on this very important topic. And thanks for all the work that you're doing in this space. We look forward at N4 to continuing to collaborate with you and with others who have attended the session. And thank you to everyone who has attended. We hope that you stay engaged with the work that both N4 and WES are doing in this area. And did any of the panelists have any final remarks before we wrap up?
Thanks all.
Thank you very much. Thank you.
Thanks so much, everyone.
Thanks.